everyone. I'm Qirui Zheng, currently the Secretary General of Aspire. Welcome to join the podcast today. Today's topic is fertility preservation in women with breast cancer. As breast cancer outcomes continue to improve, fertility preservation has become a critical component of comprehensive care of reproductive age patients. In this episode of Aspire Ed Talk, we are very happy to join by Professor Elizabeth Ginsburg from Harvard University. Hello, Liz.
Hello, thanks for having me.
Yeah, thank you for your attending our annual Congress at Singapore as a keynote speaker. I will briefly introduce Professor Elizabeth Ginsburg. Professor Ginsburg is currently the president of American Society for Reproductive Medicine, and he held several positions within the ASRM in the past, including president of Society of SART. She is the professor of OB/GYN and reproductive biology at Harvard Medical School and the director of the reproductive endocrinology and infertility fellowship program at Brigham and Women's Hospital. She completed a medical school at Mount Sinai School of Medicine and her residency in OB/GYN and a fellowship in IEI at Brigham and Women's Hospital. She is the past medical director of the LRT program at Brigham's. Her clinical practice focuses on infertility, in vitro fertilization, and fertility preservation, and her research focus on IVF outcomes in subpopulations of patients, including cancer survivors and patients with obesity. So welcome, Liz. So first, can you tell us how fertility preservation became a core part of your work in reproductive medicine and oncology care?
Well, early in my career, I actually did a lot of menopause medicine. And because Dana-Farber Cancer Institute is connected to our hospital, Brigham and Women's Hospital, I found myself getting referred many young patients for hormone replacement who had never even talked about, nobody had talked to them about at that point doing in vitro fertilization. So we, for women with partners, started doing in vitro fertilization for these women in the late 80s, early 90s. So a long time ago. And that obviously led to my interest in fertility preservation as part of my career. Early on, we actually had an oocyte cryopreservation program, but in those days it was slow freezing and it was not very successful, unfortunately.
Okay, thank you. So how early should fertility discussions be initiated once a breast cancer diagnosis is confirmed?
We really like to see patients very soon after their diagnosis. Typically, we see patients after their pathology has been reviewed. It's clearly cancer, and they've seen a medical oncologist. So usually the medical oncologists will forward the patients to us often before they have oncotype scoring back. They may not know exactly what their treatment plan is going to be, but it's well before they're ready to start on any chemotherapy. One of the best times to see the patients is before they have their definitive surgery, because especially for young women with cancer, if they need a mastectomy or lumpectomy and radiation, even if chemotherapy is going to be part of the plan, they typically have to heal for several weeks before chemotherapy starts. And that always gives us enough time for an oocyte cryopreservation cycle or an IVF cycle. So the earliest is the best.
Okay, so we go to the clinical considerations. What is the main fertility preservation options currently available to breast cancer patients?
Well, obviously the one that most REIs prefer is either oocyte cryopreservation or embryo cryopreservation. There was a large meta-analysis done recently by some of the European centers And they found that that embryo cryopreservation had the highest live birth rate when you look at patients that have returned for treatment, followed by oocyte cryopreservation, with ovarian tissue cryopreservation coming after that. So if you want to do an intervention, I do think that is the optimal order. The tricky thing, at least in the US, is that if a couple freezes embryos together and then separate or get divorced, the male partner has equal say in utilization of the embryos. So some of our partnered couples will actually opt to freeze some eggs as well as some embryos, do both in the same cycle. The other option is to have the woman take Lupron during her chemo, or any kind of GnRH agonist during chemotherapy. And that has been shown to reduce the chance of ovarian failure and increase the live birth rate in one large randomized trial, which was thought to be really the definitive trial.
Okay. So how about the in vitro maturation, or some kind of use a different kind of control ovarian stimulation, such as letrozole, tamoxifen, etc.?
Yeah, a very good question. So we've looked at our data, and we've been doing fertility preservation for 20 years plus. We have not found an increased risk of recurrence in the patients who decided to cryopreserve eggs or embryos compared to those that didn't. In the last few years, since the reports on letrozole during ovulation induction came out, and frankly, it does look better on paper. The estradiol levels are much, much lower if you use letrozole during the stimulation. We have been doing that. There are some studies showing that the percentage of mature eggs is the same if you use letrozole, and subsequently blastulation, blastocyst development rates are the same. I think there's a lot of controversy about at what stage of development, if you're freezing embryos, you should freeze them. And I would say that we will actually freeze mature eggs and immature eggs. I think it is optimal if you do in vitro maturation before freezing the eggs. It's a little tricky right now in the US because we don't have an FDA-approved IVM media. So that's like country dependent. That again, there are other groups have also looked at their recurrence rates, and it doesn't seem to be increased by fertility preservation. Even though early on we weren't having patients suppressing estradiol levels or anything like that. We used to use tamoxifen during stimulation, which made actually the estradiol levels very, very high. One of the things that you do have to remember when patients are on letrozole during stimulation is that you need a much larger follicle diameter to get to egg maturity. So I do think that the patients end up being stimulated another day or two to get a mean diameter of 20 millimeters in at least 2 of the follicles. So again, you're pushing them further because the egg maturation rate does seem to be a bit slower.
Thank you. Yeah. So how about the ovarian transposition or some extreme uterine transplantation?
Well, for breast cancer, usually not so much of an issue. There are some groups for patients having pelvic radiations for rectal cancer or cervical cancer that you can do a uterine transposition, meaning detaching the cervix from the vagina, flipping the uterus up, and then subsequently putting it back into the pelvis. But for breast cancer, it's not an issue. In the US, we do have patients, and we do offer patients fertility preservation who have positive nodal disease. We actually have some patients with stable metastatic disease now, and those patients use gestational carriers in the US. So I think as the cancer treatments improve, we are starting to see people 5-10 years out with metastatic disease. And those patients are potentially candidates to both fertility preservation and also going through IVF even after their cancer treatment.
But for emergency case, do you use the random start protocol within?
Yes, we do. Yeah, we always do. And again, there's lots of studies looking at egg maturation rates, embryo quality, et cetera. It's the same.
Because for breast cancer, patients receive some chemotherapy, such as alkylating agents or some taxane. So do you use any protective medication aside from GnRH analog? to try to preserve ovarian function?
No, just generate agonists. I think the other thing I would mention is that now there are a lot of new immune modulators on the market that aren't exactly called chemotherapy, but the initial studies show that during treatment, AMH levels are undetectable. So the AMH levels look just as low as they do during alkylating agent chemotherapy. We just don't know yet what the recovery is going to be like. We know that after women are treated with alkylating agents, that it takes at least a year for the AMHs to recover as much as they're going to recover. We don't know that yet for the immune modulators.
Okay, thank you. In your practice, how do you balance the urgency of starting cancer treatment with the time needed for fertility preservation procedure? And are there any certain treatment regimen or cancer stage are contraindication?
Mm-hmm.
For example, the stage, patient's age, what are your opinions?
That's a really good question. So we do tend to defer to the oncologists on this. There are occasional patients that are referred to us. Generally, the oncologist will let us know this is not somebody I think has 2 weeks to freeze eggs, but she really wants to talk to you about what her options might be afterwards. So the kind of cancers that we wouldn't wait 2 weeks to freeze eggs on would be, for breast cancer, really the inflammatory breast cancers that grow incredibly fast. Those patients potentially would be candidates for ovarian tissue cryopreservation. I think it gets a little tricky because probably not quite half of breast cancer survivors, particularly the young ones, actually are fertile after chemotherapy. So certainly their likelihood of infertility is high. It's not clear whether it would be that they are best served by something like ovarian tissue freezing when most of them are not going to be menopausal. So that's one group of patients. The other group of patients, because our IVF center is in a hospital, the patients that were often sent from other places to do fertility preservation on are patients with large mediastinal or neck masses where there's encroachment on the trachea, where that's probably not a safe patient to do an egg retrieval on if you're based in a Surgery center. So those patients, I think you really need specialized anesthesia care for. And then otherwise, patients with acute leukemias that are transfusion dependent, those are very, very tricky. Some patients eat up their, even when you transfuse them, you can't get their platelets to go up. And those patients, unfortunately, aren't candidates for anything elective. And we have had some patients that really weren't considered to be safe candidates for any treatment because we couldn't get their platelets up over 10,000.
Yeah. The other thing is the safety issues because patients receive ART before chemo, and then probably they are afraid of after the pregnancy, during the 10 months pregnancy, any recurrence of the cancer or any kind of safety issue you can talk about.
Right. So it's a common concern that the patients have. None of the studies looking, and these are all retrospective studies, and you can't randomize patients to becoming pregnant or not. So they're all retrospective studies, but they all have shown no increased risk of recurrence in patients who are pregnant. The tricky thing is that of the patients that recur, they do tend to recur with larger tumors because, again, when women are pregnant, the breasts are lumpy and it's very tough to pick up a new primary. Also, mammography is not very sensitive for women who are pregnant. So the problem is really that you can't pick up a recurrence, not that you're more likely to have a recurrence. You can't pick it up as well, not that you're more likely to have a recurrence during cancer. What I found in my practice is that patients who've had bilateral mastectomies tend to be much less anxious about becoming pregnant, and then the patients who've had lumpectomy and still have breasts, So those patients in general tend to be much more anxious. And I've actually had some patients elect to have gestational carriers because they were so anxious about carrying on their own and not being able to pick up a recurrence or a new primary cancer.
Yeah. You're talking about the GnRH pretreatment. Can you tell me about the mechanism why they can some protective effect? Because we know GnRH is good for treatment of adenomyosis, endometriosis. Why in the case of cancer patient also effective?
I don't think we have any idea why it's effective. It doesn't make a lot of biological sense because there are always processes in the ovaries that cause,
Suppress the
egg
estrogen and also
apoptosis. Yeah, I don't think we know what the mechanism of the mechanism is, but it seems to be a true one.
and the other medication. I think in your presentation, you're talking about rapamycin to protect ovarian reserve, and also some literature showing S1P, that's sphingosine 1 phosphate. Also, they can increase they can decrease the risk of the PI3K, increase the PI3K AKT, also depress the caspase-3 pathway. So what is your opinion? Use this medication?
Yes. And there are animal studies actually showing that you can reduce the likelihood, you reduce the amount of apoptosis caused by chemotherapy by infusing some of these agents in patients. I'm not aware of any clinical studies. And the concern typically, and this is all mouse work, the concern typically is could these agents have some sort of effect and in counteracting the beneficial effects of chemotherapy. So they want to make sure that there's no concern about interactions. So far in the mouse studies, it does not look like that's the case. But again, mice don't live very long, so it's hard to know. I don't know of any clinical studies in humans looking at these agents, though.
Okay, so for the clinical practice, how can the providers ensure equitable access to fertility preservation, especially in time pressure and a resource limited setting? Because Harvard is a medical center, but some other countryside, it's not so easy. What is your opinion?
It's very tricky. I think I don't know how much access the centers have to portable devices for incubators. So, for example, there are certain circumstances during COVID we did this where you can do an egg retrieval, for example, in the main hospital operating room, and then have the eggs in a portable incubator to be able to bring to the fertility center for cryopreservation. But there would have to be a relationship sorted out in advance between the fertility center and the oncology practice. And having a nurse coordinator is very, very helpful. We have somebody full-time that deals with all the communication between the patients and making sure they have medication, and also making sure the oncology team knows when their egg retrieval is going to be or when the ovarian tissue is going to be harvested, so they can get directly into their chemotherapy and have it planned in advance. So the communications is tricky, and you really need to put some resources into it. It's tough because it's not inexpensive to have somebody paid just to do this kind of coordination.
European groups such as Jack Donet from Belgium, they use a lot of ovarian tissue cryopreservation, and some people prefer, you just mentioned oocyte cryo or embryo cryopreservation. But why do you compare these two technologies?
I mean, I prefer oocyte and embryo cryopreservation, specifically in the breast cancer population, because it's so unusual that they are actually sterilized from their chemotherapy. I do think that if it's a sterilizing type of chemotherapy, such as the patients that are going to get a bone marrow or a stem cell transplant, patients with rectal cancer getting radiation, I do think that ovarian tissue freezing it makes sense. And frankly, you can do both for some patients if there's not a rush to starting chemotherapy. We've had patients start their ovarian stimulation. We do an ovarian tissue harvesting maybe 4 or 5 days into the stimulation when the ovaries are still small enough that you can get tissue, just to try to get everything going quickly. And some patients have done both, but we typically reserve that for patients who are really, really have a high chance of completely being sterilized. And the other thing for the patients is, so far, we still need to put that tissue back into the patient. So for patients who've had uterine radiation, like a rectal cancer patient, then they would need the tissue replaced, and then they're going to need IVF with a gestational carrier. So it's a lot of different procedures for them. Whereas if you were to do oocyte cryopreservation, hopefully you've gotten enough eggs that's that for them in terms of the procedure. So that's my preference. We're hoping that at some point we'll be able to get eggs from the tissue to mature. I don't know of any human pregnancies from that yet, but that would be ideal. And then I don't think there would be as much of a disadvantage of doing tissue freezing.
Yeah, so if the patient is young and the quality is good, overall the AMH high, maybe you mentioned oocyte cryopreservation or embryo cryopreservation is the best option. I agree. Yeah.
That's my preference, yeah.
You could change one thing about how fertility preservation is approached in breast cancer care, what would it be?
Well, I really wish it was covered by all insurances, including the state insurance, because it's very tough. I don't know about in other countries, but in the US, it's very variable. In Massachusetts, where I practice, most commercial, very good quality insurances will cover ovarian tissue freezing or the process to remove tissue or oocyte or embryo cryopreservation for patients with cancer. But people who don't have good insurance or who are insured by the federal government, if they're a government employee, they don't have any coverage and it's all out of pocket. And a lot of people can't come up with thousands of dollars. My hospital will discount it and do a cycle at cost for people that don't have a lot of income, but still even a few $1,000s for some people is impossible. So to me, it's the finances of it that are really sad.
You know, in Japan, Professor Nao Suzuki, he organized a nationwide for those patients with coming for fertility preservation because they included 240 clinics all over Japan and send all the cancer patients to specific medical center. So I think it's supported by government budget. So that I think is very, very good one. Yeah, good one.
That's great. I would love that, and we're working on it here. So we'll see what happens.
So, and what advice would you give to the clinician who wants to improve oncofertility discussion in their practice? Your advice.
I think for the REI, it's critical that you get to know the oncologists in your area. Obviously, somebody's not going to be flying, 12 hours to get fertility preservation, but to know the oncologists in your area, I think is critical, and also to give them very, very prompt ways of getting to you. So before we had a nurse navigator, before we had a full-time nurse, they all had my cell phone number. So I would get texts or called if there was a patient needing fertility preservation, but the communication piece is critical because the oncologists, frankly, have so much to do to get the patient counseled, to get the patient into treatment, to make sure that all the paperwork is through so they can start their treatment. The fertility preservation is another thing on their plate. So if you can make that easier, you're much more likely, I think, to get the referrals promptly. So that would be my strong recommendation, is to meet with them and make sure they have your contact information.
Okay, I think breast cancer is the most easy cancer patient to do the fertility preservation because sometimes they do not need many radiotherapy because they are very far away from the pelvic region. So today I'm very happy to have Professor Ginsburg with us to talk about the fertility preservation in women with breast cancer and drawing from the clinical experience and the research. I think Professor Ginsburg already explored the fertility challenges the young breast cancer patient face and the current preservation options and how reproductive and oncology teams can better collaborate. Designed for clinicians, embryologists, and fertility nurses, this episode delivers evidence-based strategies for improving oncofertility outcomes. So thank you so much, and we'll see you very soon in San Antonio as you are caliber of president of ASIM. And welcome back to Aspire again in the near future.